Good evening, class. This is my presentation on HIV, short form of human immunodeficiency virus infection. It's a retrovirus that causes viral illness that destroys CD4 and T lymphocytes, and these are the cells and that are responsible for our immune system. About 36.9 million people are living with HIV or AIDS worldwide. 51% of HIV patients are women worldwide. Persons aged 20 to 29 years are the most infected. 1,100,000 people currently living in the US have HIV. Of this, 260,000 are women. 1,974 transgender women have HIV. 1 in every 5 women in the population is infected with HIV in the US. Modes of transmission include sexual contact with the infected body fluids, contact with infected blood or blood products via transfusion, organ transplant, and shared needles. Vertical transmission from an infected mother to an infant prenatally at birth or during breastfeeding. Transmission through blood transfusion apparently is less than 1%. Oral genital transmission according to literature, is less. The main form of transmission is vaginal and anal sex. Receptive fellatio and insertive canine looks, receptive anal sex is 35 times more likely to transmit HIV than receptive vaginal sex. Maternal, perinatal, and fetal risk include elevated viral load, symptomatic disease, and also HIV can pass through the placenta to the infected and infect the fetus. During labor and delivery, the baby may be exposed to the virus from mom's blood or other fluids. And once the amniotic sac is ruptured, the risk of the baby getting the infection increases. Breastfeeding can transmit the virus to the baby. Failure to use antiretroviral drugs during pregnancy increases the risk of the baby getting the disease. And apparently between 25 to 30% of babies born to HIV mothers who were not treated get HIV, but those who get treated, the risk of passing it to the babies is only 2%. HIV infected moms who smoke put their babies at risk of getting the virus. Patient presentation. Subjective presentations include history of exposure to bacterial, viral, parasitic, and fungal infections. For example, tuberculosis, syphilis, herpes simplex, and other STIs, that's sexually transmitted infections. Normal maladies such as vaginal itching from yeast infection, recurrent oral candidiasis, complaints of shortness of breath, fever, exercise intolerance, skin lesions, weight loss, headaches or visual disturbances, night sweats, and gait abnormalities. Objective presentations include weight loss, lymphadenopathy, oral candidiasis, recurrent folliculitis, skin lesions, recurrent cervical and anal neoplasia, non-specific genital ulcers, recurrent UTIs, recurrent PID, that's pelvic inflammatory disease, hepatosplenomegaly, mental status changes, herpes simplex infection, and genital warts. Differential diagnosis could be cytomegalovirus in a pregnant woman, candidiasis, high-grade malignant immunoblastic lymphoma, and chemotherapy. Patients who are going through chemotherapy apparently presents with symptoms like HIV, immune disorders, and severe malnutrition. Diagnostics include HIV screening for all patients who are 13 to 65 who present at the healthcare setting in the US, and they have the right to opt out. All pregnant women get HIV screening in their routine prenatal panel, and again, the patient can choose to opt out. And during the third trimester, this test is repeated. Rapid HIV tests for undocumented patients during delivery. Those who come in as ER drop-in have to get HIV testing with their prenatal panel. And also HIV enzyme immunoassay. That's the most reliable and cost-effective. That is the mainstay. Combined antigen antibody is a fourth generation, and it is being adopted by most of the hospitals because it has shortened the testing time. HIV antibody is detected between 3 to 12 weeks after exposure, and it has a varying time for incubation before it manifests. Diagnosis continued. Initial testing with the fourth generation immunoassay that detects HIV, HIV-1, HIV-2, and also HIV-1 with the antigen P24. The Western blot, which was the confirmatory test used, is no more recommended. Virologic assays could also be used in the diagnostics. HIV-1 RNA viral load plasma assay could be used to diagnose it, and also immunofluorescent assay. I'm sorry for the typos. Treatment plan includes pharmacological and is based on the DHHS guidelines, and these include treating all HIV patients with antiretroviral therapy irrespective of the CD4 counts. So even if your viral load is very low, or even negligible, you still get the antiretroviral therapy drugs. Delay combined antiretroviral therapy drugs till after first semester when HIV is diagnosed with pregnancy. Some people would come and wouldn't even know they have it till they have gone through their prenatal screening and they find out. And what the literature is saying is when this is found out during pregnancy, you can go for a monotherapy instead of the combined therapy that is the mainstay now. Common ART that could be considered for use include, and the list is here. Education. Patients require extensive teaching in health maintenance, medication adherence, and avoidance of infectious disease risks. Also, patients need to be encouraged to use latex condoms and latex dental dams for those who practice oral sex. Educate patients also on smoking cessation, and refer women who abuse drugs and alcohol to treatment programs. Encourage HIV positive moms to get vaccination and also follow up with gynecologic care. Vaginal delivery for those who have low viral load is possible, and breast milk is contraindicated. And when you have a HIV patient during pregnancy, um, it is recommended that you refer the HIV patient to an HIV specialist. Thank you very much.